Hello, this is Dr. Eldred Taylor, and we are having one of our interviews with one of our speakers, Dr. David Zava. He will be speaking at our annual American Functional Medicine Association conference at the Georgia World Congress Center in Atlanta, Georgia, November the 10th through the 12th, 2016. We are always excited to have Dr. Zava come to our meeting. He has been there for, I think, all of our meetings, and we always enjoy him, and all of our attendees enjoy him so much. He's been in this area for a long time. Dr. Zava has devoted his 40-year professional career to exploring the role of hormones in aging and disease. After completing his PhD in biochemistry at the University of Tennessee, Dr. Zava spent much of his time doing basic research on hormones and breast cancer in Texas, Switzerland, California, and Oregon. In 1998, he established ZRT Laboratory, a CLIA certified laboratory that is a front runner in the innovative development of test methods to identify hormonal imbalances that can lead to debilitating symptoms, diminished quality of life, and increased risk for cancers and many of the diseases of aging, such as diabetes, cardiovascular disease, and senile dementia. ZRT Laboratory was one of the first laboratories to develop and commercialize non-invasive saliva and dried urine and semi-invasive dried blood spots methods for testing hormones as an alternative to conventional serum testing. These hormone collection methods pioneered by ZRT have proven to be far more convenient for the patient and the healthcare provider and are proving to be extremely valuable for research studies, especially where conventional testing of serum or liquid urine are prohibitively expensive and logistically impossible. Using these unique methods of body fluid collection, ZRT is actively engaged in hormone research studies with universities, government agencies such as the NIH and the CDC, and military agencies, private physicians, and professional sports teams. In addition to his innovations in clinical laboratory testing and development and numerous scientific publications over the past 40 years, Dr. Zava co-authored a landmark book, What Your Doctor May Not Tell You About Breast Cancer, How Hormone Balance can help save your life. In this book, Dr. Zava and co-authors describe how breast cancer can be caused by hormonal imbalances that occur naturally as we age, but can be prevented if the types of hormonal imbalances are identified with testing and restored to optimal healthy levels with bioidentical hormone replacement therapy and improved lifestyle, diet, exercise, and stress reduction. That was a long introduction for a man who has a long career, and I'm very proud and happy to call him a friend of mine. And Dr. Zava will be speaking on the interplay of neuroactive steroids and neurotransmitters on behavior and well-being at our meeting in November. Dr. Zava, how are you doing?
I'm doing great, Dr. Taylor. Thanks for having me on.
Well, great. So, what do we have in store for us come November? What are you going to tell us about neuroactive steroids and neurotransmitters?
Well, I think let me explain what a neuroactive steroid is. We know all about estrogen, we know about progesterone and testosterone and those sex hormones as well as cortisol, the adrenal hormones that are having different effects on the body. When they get up to the brain, they can either be direct acting, for example, progesterone, is going to be working on GABA receptors, but progesterone is converted into a hormone called allopregnanolone. So it's converted by two enzymes. It's a 3-alpha, 5-alpha enzymes that make it into a hormone that bind to certain subunits of the GABA receptor, and that's sort of the off switch for the brain. So it's allowing the brain to calm down. And there's just so much literature coming out now about progesterone. And from a clinical perspective that when you get progesterone to a patient, often they will say, "Oh, I feel better. I'm calm." But there's also a subset of patients, about 5%, that don't do well on progesterone, and that seems to have something to do with GABA receptors and the way they're forming. So I'm going to talk a bit about that. I'm going to talk a bit about how the allopregnanolone can have beneficial effects and be what we call anxiolytic and calming. But I'm also going to talk about how in some people, like I said, the subset of people, the 5%, that have what's called premenstrual dysphoric disorder that don't do well on progesterone because their GABA receptors in the brain are put together a little bit differently. And you can, you know who those patients are. They come to you and they're the ones that have the kind of symptomatology that is associated with negative symptoms that occur after ovulation happens. So that's what we're going to talk about. Some people define it as premenstrual syndrome, but it's worse than that. It's premenstrual dysphoric disorder. So it's a big long word. I'm going to talk about that and the mechanisms involved, and I'm also talk about estrogen. We think of estrogen as a neurotransmitter because it goes in the brain and it has effects on serotonin synthesis and serotonin receptor synthesis. So it plays an important role in the brain also, and it's why people can use SSRIs and help with hot flashes, but that may have more negative side effects in the long term than the estrogens do. So they're working through similar pathways, and some people are now finding that the combinations of estrogens and SSRIs are beneficial, or other types of hormones like progesterone and SSRIs. I talk a lot about that. We have developed. You're talking about pioneering testing. So we now have a neurosteroids as well as neurotransmitter testing now in dried blood spot. So that long list of neurotransmitters going from serotonin to norepinephrine to epinephrine, et cetera. So we're looking at those in relationship to symptomatology in people. So we have developed the methods, and the methods are simple because it's just urinating or dipping a filter strip into urine and then letting it dry and shipping it back to the laboratory. What I'm excited about is looking at the levels of the stress hormones epinephrine and norepinephrine in a diurnal pattern. So that's going to be very interesting, and it is interesting that we see quite remarkable differences in people with different kinds of conditions when we're looking at those neurotransmitters throughout the day. So that's just something a little bit different from what other people have done. So we're looking at the diurnal pattern. So we'll be looking at the diurnal pattern of cortisol, cortisone, norepinephrine, epinephrine, and melatonin all at the same time. So rather than just collect a 24-hour sample, we can actually look at how that's changing throughout the day, because the norepinephrine, epinephrine should be low at night and then rise during the day and then drop off. But we see different kinds of patterns depending on the person. So those are the kind of things that I'm going to be talking about at this meeting.
So let me ask you, how are you collecting the urine throughout the day? They just do different dried urine spots throughout the day?
You just pull out a filter strip and either pee in a cup and dip the filter strip and then hang it up to dry, or you can urinate directly on the filter strip and hang it up to dry. So and we're able to extract the neurotransmitters directly from that strip. We've had to do some tricks for the catecholamines because they're a little more sensitive. So they die faster on the vine, so we had to do some tricks to preserve a little bit better. But that it's working great. So it's very interesting, some really interesting data, because normally you'd look at either one time during the day, you might look at a second urine sample, or you might look at a 24-hour urine sample. It's kind of like looking at cortisol just one time, and you know that.
Mm-hmm.
You know from your clinical experience that it's kind of difficult to look at cortisol just once, because you really don't know what's going on. Well, the norepinephrine and epinephrine, they're produced by the peripheral sympathetic nervous system, and epinephrine is produced in the adrenal medulla. So these are, we call them neurotransmitters, but
Hmm.
they're really produced and excreted, or not excreted, but uh, put into the body, into the circulatory system, where they make their way to the brain, and they're excreted into urine in that form. So we can see, when there is stress, when there are a number of different things that are happening that can affect the epinephrine and norepinephrine at specific times of the day, because we're looking at least four samples. We do first morning, and that one is usually low, and then the second morning, and that one should be going up, and then a third sample, which is in the afternoon, which really should be the highest sample. And then before you go to bed at night, you should be coming back down again. Because if you're not coming back down again, then you're still in the sympathetic mode. You're
Yeah.
still in the stress mode, and it tells you that you probably need to calm down a bit.
Yeah.
So it's probably from, it's what, like we do. We work too much and we work
Yeah.
too late at night. So
And,
so that we see that.
the other problem is I've gotten interested in this. It's almost like looking at that the stress response, and you're backing up. We used to focus on cortisol. Now
Right.
I've started focusing on, okay, what gets it started, because by the time you get to cortisol, they're in a chronic stress state then, when cortisol starts to be abnormal. So
Right.
I've been interested in heart rate variability, I guess because I have this OBGYN background. And
Hmm.
the other thing that can happen is, initially, in what can happen if they're low on neurotransmitters, instead of raising their epinephrine, they'll just suppress their parasympathetic. So you could actually have, and this is how I think of it, and you could tell me differently, is that you could have normal epinephrine and norepinephrine output, but your parasympathetics, to balance it out, has been depleted, and they're still in this stress state.
Right. Yeah,
Mhm.
there's all different sorts of scenarios, and epinephrine is absolutely essential for normal heart rate.
Right.
So, and that's coming out of the adrenal medulla. So,
Yeah.
we're it's a discovery process, and we're seeing some very interesting things with regard to people who have, more problems with heart rate variability, are
Hmm.
generally tending to make less epinephrine.
Epinephrine. Yeah, and that's kind of the end stage. When uh, how I explain it to patients is that the last thing your body wants to do is to not be able to survive and protect itself. So it's going to
Correct.
suppress the parasympathetic. It's going to do all of that. By the time it starts suppressing epinephrine and norepinephrine, you're really in bad shape. And also, I
Right.
don't know. We talk about these proton pump inhibitors and call it causing dementia. Part of the other problem is that patients have low stomach acid. They can't break down protein. So if they can't break down protein, you don't even have the building blocks for amino acid. I mean, for neurotransmitters. So
Right.
it's a lot of that's very interesting. I didn't know you were doing that, Dr. Zoff. I'm sure you also do you normally see serotonin and dopamine, are they routinely low when you measure it?
Yeah, they're a little bit more difficult to interpret because
Mm-hmm.
your gut makes a lot of
All
those,
right,
and
right,
so
right,
it's I'm not sure that that I can say unequivocally that
right,
when we look at those neurotransmitters, that there's so many different factors that
right.
are going to come into play with regard to those, but there are others, the glutamate, um, certainly the serotonin. We're not going to stop at and we're gonna head towards the dry blood spot, because it's very clear that, for example, serotonin levels are in platelets, which are really trapped in dry blood spots, are closely related to um, premenstrual dysphoric disorder, depression, all different sorts of things. So that gives you an index of the serotonin levels in the blood circulation. So we're putting all this together, and because we monitor symptoms in people, we monitor the drugs that people are taking. I'd say that's the biggest challenge, as you would know, that trying to figure all this out, the big picture with regard to what people are taking for anxiety or depression or whatever. There's all different sorts. It's polypharmacy.
Right.
And then the hormones certainly come into place. Progesterone is pretty remarkable, and it's for
Mhm.
most people, and it's sleep-inducing, anxiolytic kinds of effects, and we're able to actually monitor the levels of allopregnanolone, and we know that women who use oral progesterone are going to make more allopregnanolone, so they're it's sleepy time.
Mhm. Yeah.
They take it at night, and it helps them sleep, and that's the allopregnanolone levels are going up in those individuals. So there's that. It's all of that interplay, in the brain,
Mhm.
that's going on with the neurotransmitters. And I'll talk somewhat about the limitations of being able to look at what's in urine and try to interpret what's going on in the brain.
Right.
Where it does correlate well and where it doesn't correlate very well. And um, you know, dopamine and some of the others are a little more difficult. Serotonin, because they are produced by the gut. So if your gut's not working right, you could be
Yeah.
producing a whole lot of those things, and it makes the interpretation of those neurotransmitters in urine a bit more difficult.
Yeah. All right, Dr. Zava, we start talking and we'll be on this conversation for an hour. We've had a
Right,
lot of these long discussions.
right.
So
Yeah, we have.
let me stop before I try and pull too much information out of you, and then nobody has to come and hear you speak, because I'm going to ask you enough questions where I'm going to try and pull everything out of you. But so let's stop here. And again, Dr. Zava, he's had this lab for quite some time, but he keeps adding new testing. He stays on the forefront of all of these different methods of testing. So ZRT Labs is his lab, and he will be exhibiting there also. So again, Dr. Zava, thank you. I know it's been a long day, and I appreciate you giving us the time to talk with us and tell us about what you'll be speaking about in November. And as always, we look forward to seeing you then.
Okay, thanks, Dr. Taylor.
Okay. All right. Thanks so
I'll
much.
see you soon.
See you soon. All right. Bye bye.
Bye bye.